It says that oseltamivir and possibly zanamivir may confer benefit in long-term care residents, but the evidence supporting that practice remains low certainty and methodologically limited. That matters because current guideline recommendations are being made on a surprisingly fragile evidentiary foundation. The authors call for adequately powered randomized controlled trials, ideally including baloxavir, to clarify whether prophylaxis truly improves resident-level outcomes in this setting. My bottom line is this. In long-term care influenza outbreaks, oseltamivir still appears to be the most credible prophylactic option based on the currently available data, but we should be honest that the signal is suggestive rather than definitive.
Until stronger trials are available, prophylaxis decisions should remain individualized, balancing outbreak context, resident vulnerability, tolerability, logistics, and the limitations of the underlying evidence. Until stronger trials are available, prophylaxis decisions should remain individualized, balancing outbreak context, resident vulnerability, tolerability, logistics, and the limitations of the underlying evidence. Today I want to review a very relevant paper for anyone managing influenza outbreaks in nursing homes or other long-term care settings. This study is a systematic review and meta-analysis evaluating influenza antiviral prophylaxis for long-term care residents, with a specific focus on oseltamivir, zanamivir, and baloxavir. The clinical question is important because current guidelines recommend post-exposure chemoprophylaxis in these facilities, but the evidence base has always felt thinner than many of us would like. The investigators searched multiple databases from inception through August 16, 2023, and included randomized controlled trials and observational studies involving adult long-term care residents who received antiviral prophylaxis. Their primary outcomes were symptomatic test-confirmed influenza, influenza-like illness, and laboratory-identified influenza, irrespective of symptoms. They pooled intervention-specific proportions and, when direct placebo comparisons were available, also calculated risk ratios. Risk of bias was assessed using standard Cochrane and Joanna-Briggs tools, and certainty of evidence was graded using GRADE. In total, they included 14 studies with 12,672 residents. 5 were randomized trials, and 9 were observational studies. Most of the evidence involved oseltamivir or zanamivir. Importantly, no baloxavir study met inclusion criteria, so despite baloxavir being part of the author's original scope, the review really provides no usable efficacy signal for baloxavir in the long-term care setting. The study population was elderly, with a mean age of about 76.8 years, and nearly 80% had been vaccinated against influenza in the preceding year. Now to the main findings. Oseltamivir had the lowest pooled proportion of symptomatic, test-confirmed influenza at 0.7%, with a 95% confidence interval of 0.1% to 4.7%. Zanamivir was next at 3.0%, with a 95% confidence interval of 0.9% to 9.4%. For influenza-like illness, oseltamivir again had the lowest pooled proportion at 2.8%, compared with 3.4% for zanamivir and higher point estimates for placebo, no intervention, and older comparator antivirals such as amantadine or rimantadine. So, directionally, the signal favors oseltamivir and probably zanamivir as well. But this is the critical nuance. Despite those lower point estimates, the direct comparative analyses did not show statistically significant reductions versus placebo. For symptomatic test-confirmed influenza, the risk ratio for oseltamivir versus placebo was 0.51, but the confidence interval was 0.13 to 2.07. For zanamivir, the risk ratio was 0.66, with a confidence interval of 0.36 to 1.20. Similar imprecision was seen for influenza-like illness and for laboratory-identified infection regardless of symptoms. In other words, the point estimates look favorable, but the confidence intervals are wide and cross-unity, so the data do not allow a definitive efficacy claim. The authors argue, and I think correctly, that the central problem is inadequate statistical power. Even though 14 studies were included, the actual number contributing to each pooled analysis was small, and many estimates were derived from very limited sample sizes. There was also evidence of publication bias in most outcomes, variability in outbreak definitions, inconsistency in prophylaxis duration, and heterogeneity introduced by combining randomized and observational data. On top of that, hospitalization and mortality could not be meaningfully meta-analyzed because those data were sparse and follow-up was heterogeneous. Overall, the certainty of evidence was low. So, what is the practical takeaway for physicians? This paper does not say antiviral prophylaxis is ineffective.